now we're coming to the last speaker, the only lady in the interdisciplinary group. It's An-Sofie Goessaert. She's a PhD doctor of urology with a focus on Nocturia, one of the few doctors' PhD thesis on Nocturia. She works together with Karl Everard and with Johan van der Welle in Ghent, and she's a future hope on the pathophysiology of Nocturia, and she has just published the first article, understood, in the Journal of Urology, and she's introducing us a little bit in her research. An-Sofie, please go ahead.
Thank you for the introduction. Now, I'm going to talk to you about different patient characteristics of the Nocturia population. To do so, there are three important questions. Does the definition of Nocturia matter? Does age matter? And does gender matter? Well, we know that the official definition of Nocturia is getting up once or more to void at night. However, in many studies, they use the clinically relevant definition of getting up twice or more. That's because there's evidence that the negative effect of Nocturia on quality of life and quality of sleep actually starts when you get up twice or more. We also know that Nocturia prevalence increases with age. This has to do with a decrease in bladder volume and a decrease in the circadian rhythm of hormones involved in diuresis, leading to an increased nocturnal urine production. And there must also be a gender difference because we see that women respond different to antidiuretic treatment compared to men. So there are a lot of things going on. Now, to formulate an answer to these questions, I would like to use the results of a study we've done in about 130 patients. This is quite a full table, but what I want to point out that in patients below 65 years old who get up once at night, you actually see that they have a significantly lower bladder capacity compared to those who do not get up at night. In those who get up twice or more, we also find a smaller bladder capacity, which does not only lead to nocturia, but also to an increased voiding frequency during daytime. And at the other hand, we also find a significantly increased nocturnal voided volume. This has to do with a lower nocturnal osmolality at night, at one hand, and an increased nocturnal sodium excretion at the other hand, indicating that there is an impairment of several hormones involved in diuresis. If we look at the same parameters in a population above 65 years old, we see that there's actually no significant difference between getting up once at night or not having to get up to void at night. But yet again, in those who get up twice at night, we see that there's a small bladder capacity and an increase in the nocturnal voided volume. This increased nocturnal voided volume is related more to a change in day-to-night ratio of osmolality. And sodium excretion seems to matter less compared to the younger adults because regardless of the number of nocturia episodes, we see that there is an increased sodium excretion. Now, we can use the frequency volume charts to define the main cause of nocturia, being reduced bladder capacity, nocturnal polyuria, a combination of these two, or polyuria. If we look at the distribution of these causes by nocturia frequency, we see that in those who get up once at night, in about 1 to 5 patients, we find a reduced bladder capacity. In 1 to 5, we find nocturnal polyuria, and about 1 to 5, we find polyuria. 30% present with a combination of a small bladder and increased urine production at night. If we look at those who get up twice at night or more, we see that the combination of a small bladder capacity and an increased nocturnal urine production goes up to about 60%. If we look at the distribution by age, we see that there's actually no difference between those below 65 and above 65. About half of the patients have a combination of a small bladder capacity and nocturnal polyuria. Looking at the distribution by gender, we find in women more importance of reduced bladder capacity and polyuria compared to men. In men, it seems that nocturnal polyuria, whether or not combined with a small bladder capacity, seems to play a major role in nocturia. Now, these are obviously not the only characteristics. There are also a few lifestyle characteristics that might influence the presence of nocturia. As we heard before, there is a link between obesity and nocturia. This is found in both genders. Fluid intake can obviously also play a role in nocturia. In men, we find higher evening fluid consumption. In women, we find a significantly higher mean 24-hour urine output related to fluid intake. Smoking is a difficult one because we find very inclusive reports varying from an inverse association between smoking and nocturia or to no association at all. Now, to conclude, we go back to the three questions that I mentioned before. Does definition matter? Now, if you get up once at night, we see that the main problem is an isolated cause. It can be reduced bladder capacity, nocturnal polyuria, or polyuria. This means that we could use a single treatment option, a monotherapy. However, here the question raises if treatment is required at all. If you get up twice or more at night, we see that the majority has a combination of causes. And this might be the reason why monotherapy fails in these patients. So we need to evolve to a combination of therapy. Second question, does age matter? Based on my results, we see that regardless of age, there is a similar distribution of isolated and combined causes. We did see that the hormonal imbalance involved in diuresis seemed to be more a physiologic process in those aged above 65 years old, because it's regardless of the number of nocturia episodes. Whereas in younger patients, we see that an increased sodium excretion is found in those getting up twice or more at night, which means that there is a pathophysiologic process behind that. Now, other studies also show that a reduced bladder capacity is found more frequently in younger subjects and nocturnal polyuria in older subjects. Last question, does gender matter? Well, in women, we find more small bladders and polyuria-related causes, so maybe we should go focusing on bladder and drinking habits in women. In men, we see that there's more nocturnal polyuria, whether or not with small bladder capacity. So in men, we should focus on nocturnal voided volume. Now, as you see, I do not have clear answers on these questions. All these questions raise more questions. So the only conclusion actually is that there is a large heterogeneity of the patients and that we really need an individualized approach to find the optimal therapeutic approach. Thank you very much.
An-Sofie, thank you very much. Is there any questions from the audience? Please introduce yourself, Daniel.
Hello. Daniel. Hello, Daniel Moser, University of Campinas, Brazil. I have a question for you and for the others too. Maybe one more question. Does cultural aspects interfere? Because what happens? I like nocturia. I have patients with nocturia. I diagnose them, and I say, let's treat. No, doctor, I wake up 3 or 4 nights, but it's all right. I don't want to treat. I don't know. In Brazil, it's a lot of patients like this. I don't know in other countries if it's like the same thing. What do you think about it?
Yeah, well, that's a very important thing that you mentioned, because, well, some people do get up 3 times at night, but after they get up, they fall back asleep and they are not really bothered by it. Whereas other patients who get up only once at night lie awake for a couple of hours and they will mention that it's very bothersome. So I do believe that the main reason to treat a patient, certainly from a urologic perspective, is if they are bothered. Because if they aren't bothered at all, you should question if it's necessary. However, it's as Johan van der Walle mentioned, if you have a patient at 25 getting up once at night, you might expect him to get up twice or 3 times at night when he gets older. And we know that there's a negative effect on morbidity, mortality, and things like that. So you should balance both things, bother, but also the risks. that patients can take by having nocturia. If you have an older patient who gets up 4 times at night, well, the risks of falling, fractures, etc., you should also take in account.
Just for compliment, I agree with you, and we, as physicians, become in a difficult situation, because it's like you say don't smoke or don't drink, that it's not good for your health. So you say let's treat, but I don't want. So
yes.
There is nothing or small little things to do to these patients. They
yes.
don't want. Okay, thank you.
I agree. Thank you.
So Peter, please introduce yourself and then ask.
Peter is here, Utrecht, the Netherlands. What's bladder capacity?
Sorry?
What is bladder capacity?
How do you mean?
Your definition.
Of reduced bladder capacity?
No, of bladder capacity. It's on all your slides.
Yes,
you use bladder
the functional
capacity.
bladder capacity, yes. That's
functional bladder capacity.
Yeah.
And what's that?
That's the average of the voided volume that we take.
The average, and what do you average?
Well, if you have the frequency volume chart and you have the
Yes.
different volumes of the micturitions, we take the average
Okay.
during daytime and during nighttime, and that way we have the functional bladder capacity, because
Okay.
we do not measure residual volume, so
Obviously.
that's
no.
the functional
No,
bladder
no,
capacity.
no. Okay, we are a bit in and a bit outside ICS, but those are all not ICS defined terms, so I need to know what your definition is.
Okay.
Thanks for explaining.
Okay, thank you.
So An-Sofie, I've got a small addition, because I'm mainly a urologist dealing mainly with men, and my biggest group of clients are BPH, LUTS BPH men. And we just conducted a trial where we looked on these men and looked specifically on Nocturia. And the problem with the men is they have storage symptoms, they have voiding symptoms, sometimes they have post-micturition symptoms. And they come to your hospital and ask for the treatment of symptoms. And when you do not ask the patient what is the symptom that really bothers you, you might miss a very relevant point. So when we conducted an epidemiological trial and asked these patients about their symptoms and used this questionnaire, IPSS questionnaire, and in the follow-up period of 2 to 4 years, we asked them again, and then we analyzed which of the symptoms was mainly responsible for doctor consultations, we found out it's Nocturia. And then it came to me that we have to ask the patient, what is now the symptoms you would like to have treated? So we need a very individual treatment approach according to the patient wish. Like your point was, if he voids 3 times, he's not bothered, so don't care about the treatment. But sometimes the patient is bothered by Nocturia, but actually is not expressing this. He's expressing this behind storage and voiding symptoms, so we might miss the points. And then I've got a second big group of clients. These are the patients, the home office urologist asked me to do a TURP, and then I find out they have already 3 TURPs. Then I ask the patient, what is actually the problem? And I think these doctors can be so bad in surgery that they cannot resolve obstruction after 3 TURPs. Why should I do a 4th one? And then coming out, frequently that's Nocturia the problem. And then I asked just recently my patient, what was the reason why you were treated with the first TURP a couple of years ago? And he answered Nocturia. And we have to look on the individual components, on the individual bother, especially on those patients. And then we treat the patients accordingly, and everything should be fine afterwards, but don't repeat TURP, another TURP, another TURP, or just add another treatment. Evaluation and careful assessment of the patient seems to be really valuable. There was another question. Please introduce yourself.
Yes, I'm Eyal Goldschmidt from Israel. I'm a bit confused. I mean, I'm a clinician, and I have lots of patients or women with overactive bladder, of course, and Nocturia. And in Israel, at least, we have a contraindication giving ADH for women over the age of 70. So I have these patients with nocturia, and if they have overactive bladder syndrome, I give them, of course, antimuscarinic treatment. Doesn't help. I try with ADH. Doesn't help. I would like to hear your comments about treatment, because we've been talking a lot of underlying mechanisms and so on. If do I take urine osmolality, what does that help me? Can I help the patient? Thank you.
So let me ask you a question. Do you treat with desmopressin, like arginine vasopressin? You do, although it is not officially licensed for these older people. And I think the Israeli authorities are generous. Usually in Europe, you have an age limit of 65. So it's 70 years in Israel. Do you treat the patients with desmopressin, although they are older than 70? Do you have special precautions? Are you looking for serum sodium? Are you instructing the patients when he uses this drug?
Yes.
How do you handle this?
I always, I'm head of the urogynecologic unit, so we have the nurse, she has contact with the GP, and will take before, 3 days after, 7 days after, and so on, as I've learned. But it still is a very big problem, and personally, I don't know how I can, what tests should I do, or how can I proceed in helping these women?
So we have just finished the EU guidelines on male LUTs, and we have recommended this drug in these LUTs BPH patients as well. So for older men, we are completely aware that it's not officially licensed in men 65 years or older, but we see nocturnal polyuria, especially in this patient population. So what we have recommended, based on literature and science, we start with a baseline investigation of serum sodium, and then we repeat it on day 3, day 7, and day 30, and then after 3 to 6 months, unless it's going down. When we are changing the dose, and we are just talking about men now, when we are talking about dose increase, we are starting the same evaluation again, baseline, 3, 7, and 30, and so on. We have to be aware that women are a little bit more sensitive to the drug, and we have to be a little bit more cautious. So especially the patients who are older and have a low baseline serum sodium concentration might be the patient at risk. However, not all the patients with a low serum sodium develop symptoms. We just see them, and there are much more or many more of the women affected. They have a chance of 8% when they're 65 years or older. However, not all these 8% have symptoms like cognitive dysfunction, coma, and whatsoever you can expect. So you still have to counsel the patient. You have to measure serum sodium. This is, I think, an important information. I do it on a daily basis, and I'm well aware that it's not an official license, so I have to take special care of the patient. Yeah?
Can I add something, Matthias?
Yes, please.
I think it's very important that you know, that you identify the patient that is actually requiring a substitution for vasopressin. And that's what we're doing with our renal function profile. You cannot say, well, there's nocturnal polyuria, so we give desmopressin. You should know if the antidiuretic hormone and the impairment of it is the problem. So if you analyze urine during nighttime, you will know if it will benefit for your patient. And that's maybe where it sometimes goes wrong, if you give desmopressin and you do not get the effect you want, regardless of age, because I don't really believe in that limitation of older than 65 and you shouldn't give it. I just think we need to progress to identifying the right patient for the right treatment, and we're not there yet.
That's a very good point, because I presented a poster much earlier today, and the great amount of GPs, urologists, and gynecologists based their diagnosis, and this was OAB, BPH, and nocturnal polyuria, based on patient history, but not based on a frequency volume chart. So they ask the patient and make a clinical diagnosis, but the clinical diagnosis does not necessarily have to be the truth. So you're absolutely right, you have to apply diagnostic tests, and we would like to recommend, like all the guidelines recommend, use frequency volume charts in patients with nocturia, that you are able to discriminate the exact causes why the patient has nocturia. Nocturnal polyuria is only one cause, so if you don't have nocturnal polyuria, don't give desmopressin. It will most likely not be successful. So you have to be very, very precise.
Salvador Arlandis from Spain. Do you think there is any place for diuretics drugs in patients with nocturnal polyuria? And even if this patient doesn't have special evident lower limb edema, so there is any place? And when to give this?
Yes.
Which is the best diuretic, and not with a very big edemas?
Yes, I think that if you do, as I just mentioned, if you do analyze the urine and you find out in patients with nocturnal polyuria, and you do find out that they have an increased sodium excretion, that these are patients you could treat with diuretic treatment during daytime to make sure that they excrete their sodium during daytime, and that will lower the sodium excretion at night, leading to lower urine production at night, and thus hopefully less nocturia episodes. So I do believe there is a place for diuretic treatment. And if this is combined with a low osmolality at night, maybe a combination with desmopressin.
As a nephrologist, I want to add something. Of course, I think if you give, it's only in the ones with increased sodium excretion overnight that you should give a diuretic, and then you should give it. So you have to document it. Blindly, it does not make sense. I think it's dangerous. But in the ones with increased sodium excretion, then you have to give in the morning a diuretic with short duration of action. Because if it's a long duration of action, you have no concentrating capacity during nighttime because you have washout of your medulla. So you should give in the ones with high sodium excretion. And in those ones, you will say, oh, but they are not concentrating, but they will concentrate more overnight, or they will even become desmopressin responsive. That's what we have documented in children, but in the right subgroup, in the adults, it's the same. Is the risk, if you identify the right patient, is the risk for hyponatremia higher? I don't believe. I think, why is desmopressin giving hyponatremia? Not because it's working 24 hours. It does not work 24 hours. But because of your desmopressin, you get decreased diuresis when you are becoming hypervolemic overnight. So then you get more sodium excretion overnight, and that results in the hyponatremia and not a prolonged duration of desmopressin. Now, may I give a second comment on the different comments that have been given now? I'm a nephrologist and I'm a pediatrician. And until very recently, I thought life in adulthood is very simple. You have prostate hypertrophy, you have the overactive bladder in the women, okay, every older man has disrupted sleep. But if we look back now, from what's in children the case. Children, there's something else, and almost everybody who gets older gets hypertension. But children with enuresis, until 5 years ago, we thought they were normal except vasopressin. But children with enuresis have disrupted sleep. They have increased sodium excretion overnight, what in a subgroup might be secondary to their poor sleep. They have hypertension overnight. It's not the hypertension that causes the enuresis. It's the polyuria that causes the hypertension. And I'm convinced that the subpopulation of the adults is also like that. The only thing is, in children, we are not longer differentiating between monosymptomatic and non-monosymptomatic. you have to describe the characteristics because a lot have the combination.
And don't forget to check the electrolytes when you give furosemide. You might think it's safer than something else, but it isn't.
So obviously at the very end we are stimulating the audience very much. There's one more question, please ask, and then I think we have to cut because our time is then over. Please go ahead. Just
Daniel
introduce
Engler from Switzerland, I'm urologist. Very nice presentation, thanks for that. I'm asking a question, I think it hasn't been really discussed there. Many of the older patients I have some kind of, let's say, sleep-inducing medications or sleep medications. What is the influence? Do you look for that on Nocturia? And if so, what is the influence of that?
I have not specifically studied that, so that's a difficult one to answer. I don't know if anyone else could give any comment to that.
It's definitely true.
I think that when you start a sleep medication, the sleep will be better, the blood pressure will going down, so the diuresis will the first days go down. As physiologist, I think you will get compensatory mechanisms, and after a few days, it might be that the effect is lost. So to use sleep medication for Nocturia, I think it's not the right indication.
Yes, that was not the question, but it's kind of, what is the influence? Because this is just a subjective feeling. I think that it may lead to more incontinence during nighttime if they have the medications. If they have Nocturia, that may be the case, but I don't know if there is anybody looking for that.
We should, maybe.
So
Thank you.
Thank you very much for your questions. I think we have to come to an end because we are slightly over the time already. I would like to thank you for attending. We would like to thank you, Ferring, and I would like you to complete these questionnaires and give it to the hostesses that we can evaluate. Again, we have recorded this meeting. There may be the possibility to see it again on internet, on the ICS internet platform. Please have a look. Thank you very much for attending and have a good trip home.